and welcome to tonight's webinar that is being sponsored by BritaMed. The topic is CBCT in Canada with one of our favorite veterinarians, Dr. McTaggart. Dr. Simon, do you want to do the introduction so we can get started?
Yes, thank you. Thank you all for joining tonight. It's a real pleasure and an honor to have McTaggart with us, sharing her experience with Cone Beam CT, her VetCAT. This presentation is sort of geared towards our colleagues in Canada, but we have a number of visitors from the US as well. Before we begin, there will be a recording of the webinar, which you'll receive afterwards. You're welcome to type some questions. There should be a little chat button at the bottom of your screen. And if you type the questions, we'll be able to see them and repeat them back to Dr. McTaggart. Thank you again for joining us tonight. And we'll have some time towards the end to answer some questions as well. Sue, you want to take over?
Can do. There we are, everybody. Thanks for your patience. Out of British Columbia, where I am now, it's just 5 o'clock, but it's quite dark. And I just finished a day of work. I'm sure a lot of you have, and I really appreciate everybody here to watch this and see how excited I am about what's been happening ever since I got this cone beam. I don't regret it one bit. And I got my cone beam in May of 2019. And I was wondering how it would be to receive it and operate it in Canada. And there was a precedent in the US with about 10 at the time being used by veterinarians. And I wasn't sure what the delivery and support would be like. But I went ahead with acquisition after reassurance by the existing users in the States. And since then, I've received inquiries from colleagues interested in my experience and wanting to know how it could work for them. And since I'm the only one in Canada so far with this technology, I decided to create a webinar to introduce this piece of equipment and show how I made it work well in my practice. Once I started using the cone beam, I found it changed both my surgical and medical approach to cases. And it also gave me access to a knowledge resource that I never imagined to be possible. I've had weekly contact with a periodontist with experience on the human side, who is also the inventor of this cone beam for animals. And when I share a case with him, he's able to help examine the images and share with me how humans feel with the same condition. So the learning curve to navigate the data was not nearly as steep as I had feared, because it was facilitated by support from David Sarment, who is actually hosting this meeting. So this is what the cone beam looks like. And this is Greg, who came on site from Zoran and set it up for us. I was just talking to Greg because they were just here today doing an update on it. And Greg's grown a great big beard. He says he grows one every year in August so that by December, he looks like Santa. And he just announced to me that he's just had a second grandchild born today. So that's what I wanted to tell you guys. So the following is a video of a typical scan with this machine. And the scan takes 20 seconds and then another minute for the data to appear. So it's really quite quick. This machine, you can just move it around into different rooms. You can move it up to the table. So now that you've seen it, I'm going to present some cases where the surgical approach to a lesion or the treatment plan were guided by the three-dimensional imaging ability of this cone beam. And after seeing the kind of information we obtained from the scans, then I'll go through how we structure charges to the clients to easily cover the cost of this equipment and make a profit. So we have TACCO, just 16 months old, and he had a swelling of the right maxilla, and a persistent 507 had been extracted by the referring vet. And there were 2 healing incisions, one for the extraction site of 507 and the other where an attempt had been made to extract an embedded tooth seen on a 2-dimensional radiograph. And this is the lateral bisecting angle 2-dimensional view. So you can see the embedded tooth 107 there. And this dorsal-ventral 2-dimensional view shows the embedded tooth from another perspective. In this axial cone beam view, you can actually measure the distance from the palate to the embedded tooth. And if you click on a spot and draw a line to another spot on the cone beam, it'll show the distance without the need for calculations or conversion. And this coronal view allows us to measure from a clinical location, which was the distal aspect of tooth 104. So my surgical approach was perfectly situated over the embedded tooth by triangulating the 2 measurements. And this 3-dimensional view gives a real feel for the surrounding structures and a good picture of where this tooth sits beneath the bone. And there's another view, you can just see it right there. And finally, this view really helps me plan my extraction as the orientation of the crown is obvious. It's a bit like delivering a baby and being able to see the crown ahead of time. And there's the tooth. So the tooth has been extracted via a window in the buccal bone guided by the cone beam measurements. And there's some air density that was apparent post-extraction. The osteotomy defect can be seen in this coronal view. So 6 weeks later, the cat came for follow-up and we were able to obtain another scan. And it shows the cyst is reduced in size. And this image, this cone beam allows one to compare scans obtained at different times. So on the left is a cone beam showing the osteotomy defect created in order to extract the tooth. And on the right, there's evidence that the defect is healing. So it was wonderful to be able to show that to the owners and to know it. So TACCO gets to keep her face, thanks to the ability to delicately approach an embedded tooth guided by the cone beam. This is my dog Norm, who's worked in the clinic since puppyhood for 10 years. And as we go along, I'm going to show you how he participates. Okay, Ernie is a 7-year-old Maltese referred because the mesiobuccal root of tooth 109 could not be retrieved during extraction of this tooth 3 months ago. And actually, I think the referring vet was wanting to be on this webinar because this case just came in a couple of days ago. Anyway, the root can be seen in this axial view. It's angled palatally and it's beneath a ledge of bone, which makes it difficult to visualize in the mouth if you try to go after it. You know you'll have to insert the luxator around the root tip at the same angle to be successful if you can even find it after 3 months of healing. So the white arrow here in this view shows the mesiobuccal root tip of tooth 109. It's a coronal view. The tooth had been rotated before it was extracted, such that this root, the mesiobuccal, was palatal rather than buccal. The yellow arrow shows the distal root of tooth 108. So the cone beam allows for those, again, direct measurements. And the root was located 3 millimeters distal to the distal root of tooth 108 and about 9 millimeters palatal to the buccal bone of the maxilla. So this radiograph shows how I was able to put a diamond burr exactly over the root tip using the measurements from the cone beam. And I successfully retrieved it. I was very excited. And I was looking over this case with David yesterday, and he pointed out that this dog is a great illustration of how the cone beam can show lingual orientation of roots in the mandibular canal. Extraction can be guided by this image, including angle of approach and what side of the tooth to go in on, which of course would be lingual here. I would not attempt an apicoectomy on this dog. And as we all know, the roots are generally on the buccal side of the canal. Okay, here's Mira, 3-year-old spayed female domestic short hair, left-sided oral inflammation, had not improved with medication. The lips were enlarged on the left, There was caudal left-sided mucositis. There was accumulation of plaque on the caudal cheek teeth, only on the left. There's a furcation exposure grade 3 of 208. And here's our two-dimensional radiograph, which doesn't correlate well with the clinical picture of furcation exposure grade 3 involving tooth 208. The mandibular two-dimensional radiographs are a bit more relieving. I used to think the two-dimension was perfectly revealing for mandibular pathology. However, in another case coming up, I'm going to illustrate how 2D radiographs of the mandible fail to show significant lesions, which become apparent on a cone beam scan. This axial cone beam view shows bone loss involving the left orbit. 208 and 209 have been extracted. The bone loss becomes more extensive as you scan distally through the images. As you move distally in the cone beam scan, the mandibular lesions also appear. Osteomyelitis of the left maxilla was diagnosed based on the radiographic appearance. And the distance through the alveolus to the floor of the orbit is just 5 millimeters. An accurate measurement can be obtained, as mentioned earlier, simply by drawing a line connecting 2 points. And this three-dimensional view obtained right after extracting 208 shows the anatomy of the alveolar margins. The left is on our right and the cat's facing us. So look at this. I'm using this for teaching. There's the two mesial roots and there's the distal root. And sometimes, I remember when I was first learning to extract, I would fall into this pit wondering if it was the distal root. So everybody has to watch out for that little depression that they naturally have. So now we're behind the cat and the lesions are on our left. And you can see the pitting in the floor of the orbit. So Mira returned later for extraction of the remaining left cheek teeth and her condition has resolved. The cone beam views revealing the severity of the osteomyelitis changed my treatment plan. I prescribed longer-term antibiotics and a radiographic follow-up sooner than I otherwise would have. The owner was also much more motivated both to administer the antibiotics and to return for follow-up. So here's Norm with clients during COVID, helping them wait for their pet. Here's Lola, a 7-year-old Chihuahua rescue, a weird looking left eye, and she was just admitted here for dental care. There was a strange density appeared on a radiograph, and it was difficult to locate using the two-dimensional radiographs, so we relied on the cone beam for this. So here we've got coronal, sagittal, and axial views of the mass, which is in the left orbit. The 3D image shows it really well. And there's now an ophthalmologist in the States who has the Zoran cone beam, and he's a valuable resource when a curious eye problem arises like this. He mentioned that this is most likely a bony orbital tumor or reactive bone proliferation. It could be a benign orbital osteoma, but it could also be a chondroma rodens, which is a locally invasive malignant tumor, or osteosarcoma with metastatic potential. There's another case illustrating how by screening animals using the cone beam, occult disease can be unveiled. So Norm also exercises with my husband to stay in shape for work and because he was part of our rowing team at the clinic. So here's LT. He's 12 years old and the owner felt he had oral pain. And he had been to a veterinary dentist recently who'd extracted teeth, but it didn't seem to help. The symphysis was lax and there was dorsal displacement of the right mandible. And this 3D image shows the minor extent of the displacement, likely from a previous injury. The temporomandibular joints can be affected by jaw injuries and could be a source of pain. The radiology report indicated no osteoarthritis, but there was narrowing of the joint space. And David Sarment can comment on how TMJ joint pain is diagnosed in the human. We were able to rule out TMJ luxation, subluxation, degenerative joint disease, sclerosis, and cysts using the cone beam. The ear canals were ruled out as a source of pain. Being able to look at the middle ear and the tympanic bullae in this way got me excited. So we've started a study in conjunction with, so far, one other veterinary dentist, and we've just got preliminary data, which was compiled by Dr. Sarment. So once we get more data, we may have a better idea of how occult ear disease exists in our patients. And I mean, look at this about the cats. So far, we've only got 6, but already 41% of the ears showed something on the cone beam. Norm wears his own medical equipment. Here he's got a stethoscope with him. And okay, here's Gus. He's a young fella, 21 months old, and he was presented for an embedded mandibular canine tooth. Tooth 304 is missing. Obviously, the tooth requires extraction, but where is it exactly in relation to the mandibular canal? This axial cone beam image shows the lingual orientation of tooth 304. This coronal image shows also that embedded tooth 304 lies on the lingual side of the mandibular canal. Drawing a line through the embedded tooth creates the image on the right. The cone beam shows the pericoronitis around the embedded enamel and the alveolar bone encasing the apex. So embedded tooth 304 and 307 have been successfully extracted with guidance from those images. Perhaps the greatest benefit of the cone beam to my practice is in evaluating brachycephalics. I insist on a cone beam scan for every one of these patients for reasons you're going to now see. So here's Bravo, 3-year-old. He's a really nice little dog, and he had bilateral oroantral fistulas. And some right maxillary teeth had recently been extracted by the referring veterinarian, but the flap had dehisced. And the tissues had retracted and they were scarred. Here's how we position the dental x-ray cone in order to get 2D images of the right maxilla in a pug, and it's basically over the right eye. A 2D radiograph of the right maxilla indicated fairly complete extractions, and that's about it. Now you look at the axial cone beam view and you can see the loss of palatal bone. And this is a necrotic section of palatal bone that was removed from the dehisced extraction site. And we're left with soft tissue and an oroantral fistula. On the left, the story was the same, except the tissues had not yet been manipulated. Here's a 2D view of the left maxilla. Fistula was very extensive. Necrotic palatal bone was removed from the left side as well. It was sutured up with fingers crossed. Pseudomonas was cultured. And 3 months later, this is what we had. Now, we can compare the cone beams from the different dates. The initial CBCT scan is on the left. And 3 months later, there's evidence of bone regrowth and remodeling seen on the right. I just love being able to do this. And here it shows on the left a 3-dimensional one from February 28, and on the right, the 3D from April 23rd. And in the right maxilla, there's evidence of bone regrowth. So Bravo's got a new lease on life, and I've been able to motivate the owners to come for rechecks. They came from far away and they weren't going to come back. But when they saw the extent of bone loss on the cone beam and how we're getting regrowth, they've been coming back. So here's my text and one of my associates in a rowing regatta, and Norm was the coxswain. So here's Sandy, and this is going to be an example of what you can do with fractures using the cone beam. This dog's jaw fractured after it went home, after tooth 408 was extracted at the referring veterinarian's hospital. And the mandible had not healed, obviously. This is a two-dimensional radiograph of my repair. But I got these thanks to David. He organized these three-dimensional images when I was first learning the cone beam. And you can see the before and after. So it shows you what you can do on this machine. So Sandy is here post-surgery wearing a tape muzzle, and Sandy went on to have a functional jaw. Here's a staff member's dog lamenting COVID and the rain. Okay, so here, Alfie, 8-year-old Sheltie, and he had a periapical lucency noted by a radiologist when they were just looking at a chest radiograph. And the referring vet had recently cleaned the teeth, but the radiographs they'd obtained didn't capture the loosened area. So here we are, it's tooth 309. You can see it there. So remember earlier I talked about two-dimensional views of the mandible, not revealing all of the pathology. Note the subtle fenestration on the lateral mandible. Let me go back to that. See that? It's amazing. I was blown away by the ability of the cone beam to show a lesion in the mandible that 2D radiographs didn't show. And up until now, I was under the impression that imaging of the maxilla was better with the cone beam, but that 2D was just fine for the mandible. Can you see it here? So the lesion and its relationship to the mandibular canal can also easily be seen on this axial cone beam view. There's the canal, and there's the lesion. It was not bilateral. Contralateral tooth 409 appears to be normal. So tooth 309 was extracted and the root was sent to Cindy Bell for analysis, as I suspected a periapical cyst, and she's doing a study of that specific pathology. And I got a nice report from her, that you can get. Here's Norm preparing to work at a seminar about bees. Okay, Lola came for malocclusion, and she has had this condition for 3 years. She had base narrow 404 and her mandible was skewed to the left. Teeth 404 and 403 had created deep defects in the palatal and incisive bones. So this coronal image shows the occlusion in a whole new way. Note the mandible skewed to the left and it's shorter. And you can see how the carnassials sit in relation to each other. Note that the left side is more distal in relation to the right side. So you can see this is 309 and this is 208. You can actually see on these images how they fit together. Never could do that before. So in the past, we were limited to noting rostral occlusion without the benefit of comparing right to left caudally. So here's our axial image, and it shows the true extent of palatal bone loss, which guided my flap design such that I knew where there would be underlying bone and where not. So after the canine tooth is shortened and 104 extracted, a palatal sliding flap was designed to effectively cover the void, and the exposed tissues on the midline healed well because they had underlying bone. And I don't know if you've had enough yet. I'm nearly done. I'm going fast. This is my last case, Charlie. He's a 5-year-old male neutered Cocker Spaniel with periodontal disease. And he needed some extractions, and we ran a cone beam scan just for general screening. And I couldn't believe it when I saw this. What was that? What the heck was that? It's not on the other side. And you can also compare the right and left sagittal views. There's a left one, it's not there on the right. And the coronal view also shows the difference between the right and left sides. There it is there. So you can send your images for a detailed report from a radiologist familiar with reading cone beams, but you know, many of them you can quite quickly become proficient at reading yourself. And it's really an awful lot of fun. You have to drag me out of there. So it's just a taste of the new world that was opened up for me by use of the cone beam technology. I'm looking at ear canals, I'm looking at temporomandibular joints, fractures, nasal masses, which I didn't even show you on this. There's got lots of those. Changes in the bone of the maxilla or the mandible, lucencies in relation to the mandibular canal, oronasal fistulas, tumors, and occlusal evaluation like we could never do before. So I'm glad I got this technology, and now I'm going to indicate to you how I afforded it. So how do we get people in for cone beams? What we do is the clients are screened before any anesthetic that they're going to get, no matter what it's for, to see if they'd like a cone beam done in addition to whatever they're booked for. The discussion includes the knowledge that animals don't communicate infirmity and that the cone beam can uncover middle ear and TMJ problems that they would otherwise not be aware of. And we're presently doing a study to find out how much occult ear disease exists in dogs and cats. So you can see on here what we're charging right now, and you add the hospital charges to that as well. And we're getting calls wanting to get the cone beam done, and we're having to turn some of the people away. We just can't fit everybody in. So after seeing the extent of the disease, people are eager to pay as well as to return for rechecks. And I'm happy to share more details of that with anyone who wants to ask me afterwards. This was a happy client to see the credit card in his hand. So I thought I might have felt burdened by the cost and the new technology of this machine. However, I've had great success incorporating it into my practice. And if you decide to take the leap, I'm sure you'll be delighted too. I'm happy to support anybody that wants to do it as they go through the process. And I want to thank everybody for attending and ask if there's any questions.
Thank you so much, Dr. McTaggart, for this review of your use and learning curve with the VetCAT. This was really fantastic. There are a few questions here. One of them from Dr. Hiscox, who just typed a question. Are there any regulatory issues with placement of a CBCT in your practice?
Okay, so we dealt with that right away, and I believe that it is provincial. So you check with your own province and your own association as to what their regulations are going to be. So as soon as we got it in, we had it inspected, and the inspector will tell you what they require. So I guess it's a matter of where you'd want to put it in your practice. I think maybe that's what Lorraine's asking. You know, do you have to have walls in between or whatever? I know Chris Bannon has got hers just sitting on the floor, and she rolls it up to the animal before they start the dentistry and takes a cone beam. So it's not in a particular room like you have to have your other big x-ray. I don't know if that answers your question, but just check with your local authorities.
So the secondary question from Dr. Hiscox, I think, is related to this, is whether there was any issues with moving it around the hospital as well, within the hospital.
Well, it goes through a regular doorway, and it rolls quite easily. And it's got little locks when you get it where you want it to be. I've even got some sills in some of my rooms, and it bumps over there, and it's quite happy. I believe, David, I was asking about that because I was worried about bumping it over a sill, and I think Greg told me they're in hospitals all over, and they go up elevators, and so maybe David can even answer that better, but I've had no trouble.
Yes, you're correct. The device can be moved within the hospital without trouble. It's designed to be moved around a human hospital as well, and like you said, it happens a lot where the machine is used in the operating room, down in a floor, and maybe brought up in an elevator and used on another floor and so on. So it's completely fine. Yeah. There's another question here from Kelly Mully. Sorry if I missed the first few minutes. What is the total initial investment for the equipment?
Okay, so that's going to depend on your purchase price. I used a lease company, and I think that if you want to know how much a cone costs to get from whatever company, if you want to know from Zoran, when you clicked to register for this, their representative to sell this is Peter, and you can see his information where you click to register. He will be quite happy to let you know. He'll give you a quote for that. But I have found that my purchase, when I leased it, so I pay monthly, I easily cover that cost with what I make on it, besides having all the fun of knowing what's really going on. So is that Kelly Mully who asked that? Welcome, Kelly. She's a colleague in town here.
Okay. Yes, and Peter actually responded to that question as well, and everybody's seen his email that they'll be able to produce a return on investments and a quote for those who are interested. Yeah, that's great. I see another question here related to the repeat scans. It seems like you showed situational 2, and you mentioned that you are, when you can, that you're interested in doing sort of compare scans. What's your experience with that? And do you do this routinely or just on selective cases for repeat imaging?
Okay, that's a really good question. Definitely for rabbits. I don't know how many of you do rabbits, but for rabbits, I do a scan every single time they come in. And I don't even take two-dimensional x-rays anymore at all, because they're just like, their whole face is like a maxilla, really. So those get repeats all the time. If I have something that I see a pathology and I want to know if it's healing, I will always do a repeat. And I also will take a scan, I had I did an ear flush. Remember, David, I showed you that. I flushed an ear, and then I took a scan afterwards. So I did a before and after procedure scan, and I found that very useful for the ear. But for dentistry as well, I think I showed you that brachycephalic, and we were seeing the bone come back. And I wouldn't have known ever what was going on before I had a cone beam. And now I can, even if I get another case like that, I have some experience in how it heals. I don't know if that answered.
Yes, I think it does. I think a follow-up question, a similar question was with regard to using if you could describe your workflow, in other words, whether you use the VetCAT as a diagnostic tool, or from time to time you actually have a case which you started and you might either take a first scan during the procedure or a repeat scan sometime during the procedure. Which situations would you do that?
Okay, so I really try hard, and I prefer to take a scan before I do anything to the face. So of course, and I also when we give them their sedative and we're getting ready to intubate, I like to do the scan before they're intubated so that I can see the occlusion. And that is really helpful. And then when would I do another scan? I think I will use my 2-dimensionals as I go along for extractions to see if a root is still there, because my initial scan will help me to locate things and I can use that. So I guess I would always do one before, and then I did one after for the ear. And then when they come back for a recheck, and you know, each year when they come in, I think they should have a screening done, which would then also be a repeat scan a year later, because you never know what changes have occurred in the TMJs, the ears, and nasal. I didn't even cover a nasal case. We are seeing a lot of changes from one side to the other in the nose, and it helps us. So I don't know if that answered your question.
I think it does. Yeah, there's several questions coming in. It's really quite amazing. A question I think actually is somewhat a little similar is: do you perform all of your CBCT under general anesthesia, or do you do some under heavy sedation?
Okay, so I do it because I want to do it before they're intubated. They'll have their pre-med, and we've got a catheter in them, and we'll give them just a little bit of Alfaxan. If they're not heavily sedated enough, we'll give them a little bit of Alfaxan. So we've got oxygen, we pre-oxygenate them, and then we just do their scan and then intubate them after that. So sometimes it's just heavy sedation, other times it's regular sedation with Alfaxan IV, I guess what you could call heavy sedation. There's the odd dog, if I think they cannot breathe at all through their nose, and we've had the odd one of those in cats, we will intubate them. And you can still do a great scan with them intubated, you just don't get the occlusion quite so well.
One more question, if you don't mind.
I don't.
Are you following up RCT and VPT with cone beam CT?
So when they come back, yes. So if I've done a root canal or vital pulpotomy and they come back, I just have them 6 months later and we heavily sedate them. At the moment, I'm using the 2D for that, but if I take a 2-dimensional radiograph and I can't see exactly, it doesn't look great, then I might go and do the cone beam to give me more information.
Excellent. Well, I'd like to thank you again, Sue, for this fantastic presentation. You've covered quite a bit of grounds. It's been a pleasure and an honor working with you, seeing you starting and progressing and becoming an expert now with the use of 3D photography.
Hi, Dr. McTaggart. Hi, David. Can you hear me?
Hi, Peter.
Oh, yes. Hi, Peter.
Sorry to interrupt you, David, but I just wanted to thank the group for those to take their time to come on. Thank you so much, Dr. McTaggart. Great to see you today. Such a great presentation, and just introducing this great tool to help a lot of the clients and patients on the island. It's the word's getting out. You're getting so busy with the service. But I also wanted to ask you about the learning curve for yourself and your staff. Perhaps there's some folks who might be interested in, you know, the length of time and some of the things that you suggest to move forward quickly. I'll hang up. I'll just mute myself after that. Thank you so much, David. Thank you, everyone, for taking the time.
Thank you. Thank you. This was Peter White, who is representing the VetCAT in Canada. He sent his email information throughout the chat if you're looking for his name and email.
Okay, so the question was the learning curve. And I think at the very beginning of this talk, I talked about, that was one of my biggest fears was, would I have the time and the ability to be able to figure this all out, not being a radiologist. And it really, it just starts intriguing you from the beginning. I think the biggest thing is navigating. You've got 3 different images on the screen, 3 different views, and 3-dimensional. And you just, I don't think I have that great an ability in this area, but I didn't have any trouble. But I mean, I was fascinated by it. I didn't have to spend a lot of time, and actually I didn't spend a lot of time learning it because I didn't have time. I would have a case and I'd be trying to figure it out and then go and jump in and fix the animal, and not a lot of time at the end of the day because you're really tired. And, you know, for the first while, like having somebody like David check in and just guide me, that just made all the difference. So no, the learning curve was nowhere near what I thought it would be. It was actually not painful at all.
That's great. That's good to hear. Thank you so much. And thanks to BritaMed and Peter White, our distributors in Canada. We have a very close relationship, and it's wonderful to have such a great company to support and help. They are very familiar with our equipment. They also distribute on the human medical side, and so they're certainly an excellent distribution company throughout Canada. And they're always ready to help and come in and support in any way they can. Thank you again, Dr. McTaggart, and thank you all for joining us tonight.
Bye.
Thanks so much. Good night.
Stay safe.
Thank you. Thanks, Peter.